Hello and welcome everyone. Today's presentation is on the IDSA guidelines on ESBL producing Enterobacteriaceae, how to manage these organisms. So looking first at the ESBL and the infections. There is an increase in the ESBL Enterobacteriaceae infections from 2012 to 2017, which is almost 53% increased isolation of these organisms in cultures. Now, the problem is we are getting more such cases coming from the community. So, which makes these a very important infection and which is something which should keep in the back of our mind before starting the empirical therapies. Now, ESBL is inactivates most penicillins, cephalosporins, aztreonam, but do not affect the non-beta-lactams, that is the ciprofloxacin, trimethoprim sulfamethoxazole, gentamicin. However, organisms with ESBL genes often carry additional genes or mutations, conferring resistance to a more broader range of antibiotics. The common organisms that carry the ESBL gene are E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis. The CTXM enzyme, especially the CTSXM15, is the most common ESBL isolated in the US. Now, routine ESBL testing is not typically conducted in any clinical microbiology lab. Instead, non-susceptibility to ceftriaxone, that is MIC more than or equal to 2 microgram per ml, is often used as an indicator of ESBL production. Now, this method has its limitation in terms of specificity. So, which is the preferred antibiotic for treatment of uncomplicated cystitis caused by ESBL Enterobacteriaceae? Now, the preferred antibiotic here is nitrofurantoin and trimethoprim sulfamethoxazole. Both are safe, effective for treating uncomplicated cystitis. Now, the alternatives are ciprofloxacin, levofloxacin, and carbapenems, which have sufficient activity against these organisms but are discouraged because to preserve their effectiveness in more severe form of infections and to minimize the associated risks. Now, the risk associated with these drugs are with the fluoroquinolones, there is a prolonged QT interval, tendinitis, tendon rupture, aortic dissection, and with the carbapenems, there is a chance of seizures, peripheral neuropathy, and Clostridium difficile infections. Now, a single dose of aminoglycoside or oral phosphomycin can be an alternative treatment in uncomplicated cystitis caused by these organisms. Phosphomycin is not suggested for infections caused by Klebsiella and several other gram-negative organisms. So keep in mind, for E. coli, you will mostly be using phosphomycin. If it is not E. coli, avoid phosphomycin. The not suggested antibiotics or the antibiotics that you should not be giving in these infections is amoxiclav and doxycycline. They are definitely not recommended due to lack of robust clinical efficacy and very high failure rates. So next, the evidence. Now, if we look at the influential trials on these therapies, the first one would be the Huttner et al. 2018 trial. It was an RCT which compared nitrofurantoin and phosphomycin in uncomplicated UTI and found nitrofurantoin to be equally effective to phosphomycin. The next is Gupta et al. In 2007. It was a study demonstrating the effectiveness of short course nitrofurantoin treatment in women with acute uncomplicated cystitis, and in this therapy, nitrofurantoin was found to be very good. Now, next is what we look for is the preferred antibiotic for treatment of pyelonephritis and complicated UTI. Now the infection got a little more severe. So if in this infection, what are we supposed to do? The recommendations. So again, trimethoprim sulfamethoxazole can be preferred. Ciprofloxacin is good enough. Levofloxacin is also good enough. Carbapenems can be used in case of resistance to all the previous agents. Now, aminoglycoside is an alternative, especially if nephrotoxicity is not a major concern for us. Fosfomycin is an alternative for prostatitis caused by E cell producing E. coli. So, E. coli, prostatitis, you can use fosfomycin. We will look into some of the trials of fosfomycin. These are the trials which looked into the efficacy of fosfomycin in E. coli infections. This was the first trial, that is 97 women of E. coli pyelonephritis treated with IV therapy followed by oral fosfomycin or ciprofloxacin, and they found equal clinical cure rates with both the groups. And next is an observational study of 44 males with chronic bacterial prostatitis treated with oral fosfomycin, and they could achieve up to 80% clinical cure rates with these therapy. Now, the limitations of the study are the low percentage of ESBL producing isolates in these particular trials, and the applicability in more drug resistant pyelonephritis cases is to be limited. Now, the alternative treatment is fosfomycin is recommended as an alternative therapy for prostatitis caused by ESL producing E. coli when other preferred antibiotics are not suitable. So, if we go back, now nitrofurantoin is not recommended in pyelonephritis because it has inadequate renal parenchyma concentrations. So, you give it only if there is a urinary tract infection, not if there is a pyelonephritis. Noxycycline is not advised due to limited urinary excretion and lack of studies. So, next we go to the preferred antibiotics for treatment of infection outside of the UTI, urinary tract, caused by the ESBL Enterobacteriaceae. So, if you look at the recommendations, the preferred antibiotic is carbapenem. Carbapenems are recommended, that is meropenem, imipenem, cilastatin, and ertapenem. This is the first line in non-urinary ESBL infections. Just a reminder, even if it is a urinary tract infection or a pyelonephritis, carbapenem is to be used if the patient is critically ill. In those cases, you are not supposed to use fluoroquinolones or the other antibiotics, trimethoprim sulfamethoxazole. So, meropenem and imipenem for critically ill patients. So, if the patient is critically ill, do not give ertapenem, go for meropenem and imipenem. We will see why. Now, meropenem has significantly lower 30-day mortality compared to piperacillin tazobactam in an RCT, which had 391 patients with ceftriaxone non-susceptible E. coli or Klebsiella pneumoniae. These were bloodstream infections. Now, the intervention, as we have seen, it is piperacillin tazobactam versus meropenem. 30-day mortality was 12% in piperacillin tazobactam, while it was only 4% in meropenem. This was statistically significant, and this clearly showed the improved outcomes with meropenem. Now, next is the ertapenem limitations. Ertapenem has several limitations because it is a very highly protein-bound drug, and this is affected, and especially in critically ill patients who have hypovolemia or hypovolemia or hypoalbuminemia. Now we look at an observational study finding on ertapenem. Since it is a very highly protein-bound drug with prolonged serum half-life, it if the protein decreases, the half-life also tends to decrease. Now, in critically ill patients who are hypovolemic, the efficacy is lowered. As I have told, the pharmacokinetics is affected. This was a study in hypoalbuminemic patients. As we have seen here, if the patient had hypoalbuminemia, that is albumin level less than 2.5, ertapenem is associated with extreme high mortality rates, especially with the common dosages. Until and unless you are adjusting your dosage for the hypoalbuminemia, do not use ertapenem, and especially in critically ill patients, because of the effect on the pharmacokinetics, it is preferable to go for meropenem or imipenem. Now, for oral step-down therapy, use trimethoprim sulfamethoxazole, ciprofloxacin, levofloxacin, and they should be considered once the patient is hemodynamically stable, there is a reasonable source control, and there is no concern regarding the intestinal absorption. So if these three criteria are met, you can go down to oral therapy. Now, the oral therapy that should not be used is nitrofurantoin, fosfomycin, amoxiclav, doxycycline, omadacycline. These all should be avoided because of their poor serum concentration and unreliable serum concentrations. Now, next is we look at the role of piperacillin tazobactam in the treatment of the ESBL Enterobacterales infection. Now, the empirical therapy for uncomplicated pyelonephritis, it is not really recommended, but if it has been started empirically and clinical improvement is noted, then you can go for no change or extension in the therapy is required. Now, alternative antibiotics that are suggested in the place of this is trimethoprim sulfamethoxazole, ciprofloxacin, levofloxacin, and carbapenems. These are to be preferred over piperacillin tazobactam in complicated UTI and pyelonephritis. Now, as we have seen, it is not recommended in any infection outside of the UTI, even if susceptibility is shown. This is very important. Even if you find the isolate is susceptible to piperacillin tazobactam, do not use it outside the urinary tract infections. Now, this is because there is a concern regarding the tazobactam's effectiveness. In vitro studies have shown that tazobactam is extremely ineffective as a beta-lactam inhibitor. There is inaccuracy in the MIC testing. There is reduced effectiveness, especially if the bacterial load is very high. And this could be one of the factors why we find worse outcomes with piperacillin tazobactam. Next is we compare piperacillin tazobactam and ertapenem in ESBL producing E. coli. It was a randomized open label trial with 66 patients. And in this they used ESBL producing E. coli in pyelonephritis or complicated UTI. So the intervention was ertapenem versus piperacillin tazobactam. And in this they found similar success with both the drugs. So piperacillin was not inferior to carbapenem in these situations. There was a subgroup analysis of bloodstream infection, or that is 231 bloodstream infections of this urinary source, and they compared piperacillin and meropenem, and they found a lower mortality rate with meropenem, though it was not statistically significant. So these are the two major trials which have compared piperacillin tazobactam with carbapenems, though it has shown similar efficacy as to statistics is concerned. However, the use outside of UTI is discouraged. So if you are finding a patient who is critically ill, it is better to go for carbapenem, or if you are looking for an alternative, go for trimethoprim sulfamethoxazole, fluoroquinolones. These will be better rather than going for piperacillin tazobactam. So next, the treatment options that are other drugs that can be used in this. First would be cefamycin. The current recommendation is not to use cefamycin. Cefoxitin, cefotetan should not be used in ESBL Enterobacterales infections. Beta-lactam inhibitors like ceftazidime avibactam, meropenem vabrobactam, imipenem cilastatin relibactam, they are effective, and their use should be restricted only in clinically sick patients in whom you find an isolate of carbapenem resistant Enterobacteriaceae. Other than that, you should not be using these beta-lactam inhibitors. Now, regarding cefiderocol, it is effective in ESBL Enterobacteriaceae, but again, it should be reserved and not used until and unless there is a carbapenem resistance. The next is ceftolozane and tazobactam. Ceftolozane tazobactam is not recommended for treating ESBL infections except in a possibility of a polymicrobial infection where you're suspecting. So finally, we'll come down to whether cefepime can be used in treating ESBL infections. As you can see here, clearly avoid cefepime. The panel is against using cefepime in any of the infections of ESBL enterobacteriaceae. In uncomplicated cystitis, if initially a therapy is started and you observe improvement, then you may not alter your treatment. Other than that, it is better to avoid. Avoid in pyelonephritis, avoid in complicated UTIs. Regarding outside urinary tract infection, avoid them, even if susceptibility is being reported. So the rationale is the ESBL's hydrolyzed cefepime and testing for susceptibility can be inaccurate because at times there is in vitro effectiveness. However, cefepime is a very weak drug, especially against ESBL organisms, and they tend to hydrolyze them in vivo more than they can do in vitro. So it is better to avoid because of treatment failure and lack of clinically effective studies. Thank you for your patience, and I hope this video was helpful. So give us a like and share this video so that it has a more reach. Thank you.